Okay, let me roll. All right, so the how can we make a real difference in healthcare? What are the challenges? And there's been a ton of research in OR and healthcare, and frankly, very little of it actually gets implemented. And I have to say that I think that a lot of that is researchers don't really appreciate the challenges in doing this in healthcare. I didn't appreciate it. I've been doing this for over 30 years, Amy said. And so what I want to do is I want to share some of the lessons that I've learned and give you some examples of, and I'm not just going to give you examples of when it worked, I'm going to give you examples of when it didn't work for each one of them, right? And I love this little car. I love Calvin and Hobbes. And so let's try this path over there. I don't see a path. We'll make a path. Oh boy. Change is invigorating. If you don't accept new challenges, you become complacent and lazy. Your life atrophies. New experiences lead to new questions and new solutions. Change forces us to experiment and adapt. That's how we learn and grow. Whoops, here's a fresh challenge. I'll admit it's opened up new horizons. The problem with new experiences is that they so rarely are the ones that you choose. I feel smarter already. Right. I love Calvin. Okay. Um, there's lots of good examples. There's actually lots of examples of operations research at an operational level. You know, like looking at nurse scheduling and looking at simple things. Amy and I were chatting earlier, and you know, with COVID, for example, you know that we've got a lot of we've been asked to do a lot of fairly simple things, not very exciting, not very big, important nonetheless. But there's been a lot of that. But I started thinking a long time ago that I was doing a lot of nickel and dime stuff in a billion-dollar industry, or in the U.S. in a trillion-dollar industry, and I wanted to try to do something at a more tactical and strategic level, and that becomes a real challenge, right? And I have to tell you, so only 5 challenges. I'm going to go through 5 challenges, and I gave a talk several years ago in the UK for the NHS, and I was asked to give a talk about the challenges of doing implementation in hospitals and in healthcare. And I could talk. There's 20, 30 challenges. I could talk for hours about all of the problems. There was a paper by Brailsford and others that talked about using the technology assessment model, and it goes on for ages on the list of things that are wrong. It's a boring list. Anyway, so when I agreed to give this talk, and then Terry Young, who was the organizer, and he actually edited my title. And instead of saying the challenges, he said the top 5 challenges of implementing. And I went, how can I cut that down to 5? They said that I could talk about 30 easily, but 5 and I'm really glad he did, because I think, as you'll see, that it makes for a much more interesting short list. What are the real 5 major things? So that's what I decided to focus on. And in fact, there's a whole bunch of other things that are encompassed within each one of the 5. Okay. And I'm going to focus on healthcare industry challenges. And I'm going to assume, this isn't about creating a good model. I mean, certainly it's a challenge if you try to implement a bad model. I'm going to assume that you've got a good model, you know what you're doing, you've tested it, you've tested usability, etc. There's also all kinds of problems and issues about external factors, regulations, competition, all kinds of things. Forget about that. Let's assume that you've done your homework, you've got a good model, you know what you're doing, and you want to be able to do this. So I'm going to go through for each the top 5 challenges in my mind. And I'm also looking for, if you can think of other ones that I've missed, by all means, let me know. And for each one of the challenges, I'm going to show you some successes. I'm going to show you some failures, and I'm going to show you some that are kind of mixed. All right. Here's a cartoon. This is a cartoon a friend of mine in the Netherlands sent me years ago. open mic night in the hospital, and I got to tell you that there are days when I felt like this, right? And I'll show you some examples. Oh yeah, anybody wants to interrupt with a question anytime, jump in there. Um, so the first thing, the first challenge is that we really need a crisis. We need a burning platform, and and the burning platform. So we really need. This is a real critical problem, and if it's a real crisis and a real critical problem, people will find the time, they'll find the money, they'll find the data. They need to believe your model will solve the problem, but they will it. We need a crisis. And unfortunately, when people have a crisis, they want a solution quickly. They want something fast, right? And that's, that, wait a minute, the quick jump, there's a burning platform. Oh, it's only smoldering, come back here. Anyway, we need something quickly. And that's quite often the problem. Unless I've already got a tool that I've developed in my back pocket, it's difficult to bring in OR to work on a crisis. So I'm going to show you this one. This is a successful one that it was a crisis, and we managed to do it in a fairly short order. And this is surgery simulation at Victoria Hospital in Saskatchewan. Now, Saskatchewan, for those who don't know, so Saskatchewan is a Canadian province north of Montana, north of North Dakota. The two major cities in Saskatchewan are Saskatoon and Regina. Most of the population lives there. Prince Albert is sort of up at the tree line. Now, beyond that, there's not much, right? So Prince Albert is about as far north as you go. And Prince Albert's about 100 miles from Saskatoon. And in 2011, the Minister of Health in Saskatchewan announced that nobody was going to wait more than 3 months for any surgery, right? That wait times were in bad shape, and they were going to fix that. And Victoria Hospital in Prince Albert, they said, well, that's great. I'm really glad, but unfortunately, right now, their average wait times for orthopedic surgery were 8 months. And when they said nobody waits more than 3 months, they're talking about the 90th percentile. So 90% of people will be done in less than 3 months. The average was 8 months. The 90th percentile was a year and a half. And so Victoria Hospital said, look, if you want us to do that, we need another orthopedic surgeon. They had 4 ORs. We need a new OR. We need another OR. We need $2 million. And so the Ministry of Health hired us because we had a model for doing surgical simulation modeling, a discrete event simulation model, and we built this. And so the Ministry of Health brought us in to go to the hospital to help them figure out, because the hospital figured they didn't have enough resources. The ministry figured they were just being inefficient. And so you can imagine, I'd really like to refer you back to the open mic night at the hospital slide. It felt a little bit like that, okay? Anyway, so we went in there and we had a project. It went on for about 4 months. We went to Prince Albert, Saskatchewan in January, in fact. They were actually lovely. They were very helpful. And what we discovered was, in fact, both things were true. They were being tremendously inefficient, but they really did need the extra OR. They did need the orthopedic surgeon. They did need the $2 million. And based on our analysis, they got it. And in a process of an analysis of about 4 months. But they did have to change what they were doing dramatically. And one of the things that we discovered as we were doing that, they were so focused on orthopedic surgeon that general surgery, it had about 90% of people were being done in 6 months. It also had to get down to 3 months. And it was, in fact, the way things were going, it was actually going to grow from 6 months to 7 months. So they had to do something about that too. But that was a success. They also had serious bed capacity issues, and this happens in a lot of hospitals. That over the there's no surgery done much, not much surgery done on the weekend, and so the surgical beds empty out, and medicine comes in and fills them up. So by Monday, the surgical beds are full of medical patients. And one of the things that in our model we discovered was that because that was the process, that they had a surgical ward that had 32 beds. And in our simulation model, we were able to demonstrate that they only needed 17. So in fact, we opened up 15 beds and we said general surgery, that medicine can have them, but we're going to ring fence and protect 17 beds. And that will eliminate cancellations and that will eliminate canceled surgery. And we were able to demonstrate that, which is something they couldn't have done on their own. So it was a really nice success. Here's one that a model of the Ontario health system, and I was asked by a director at the Ontario Ministry of Health. He said, "I want a model of the healthcare system," and he wanted to be able to test future policy decisions before spending billions of dollars. They had a recent initiative when he asked me the question. They'd spent $1.2 billion. Multiply that by 10 for US, and they wanted to add aging at home for seniors. They had no KPIs, they had no measurements, and they wanted to have measurements. So as I typically did, I gave this to a PhD student, Ali Sensoy. Ali created a great model about 5 years later. Did I mention things had to be quick? So he built this health systems model, and we went back and we tested it on a couple of old systems, so we could look retrospectively what the model would have done, and it was pretty good. Doing it at a macro level and at an order of magnitude level, and we went back to them, and now it was unfortunately it's a real data hog, and we're still waiting for the ministry to figure out how to implement or how to use it. There was interest in Wales. In Wales, the Welsh system, they actually, because their system is different, they actually created a model that was very much like this, based on this development. And we're looking at with a collaborator in Switzerland. But so far, nothing, and it's just a wonderful model. For a questionable one, we took our simulation model. We had our simulation model for surgeries, and we expanded that to be a simulation model for surgical patients and for medical patients. Most hospitals have both. Medical and surgical patients are much easier to simulate. Medical patients are more difficult. Anytime I tried to build a simulation model that included medical patients, either my hospital would explode or it would be half empty. And that never happens. Like every hospital I've ever looked at is full. They're just or close to full. And they don't blow up, and they don't run around empty. And so what happens is that when people are operating a hospital, they have what's called surge capacity protocols. So when things start to get busy, they will do diversion. They will reduce admissions. They will cancel scheduled surgery. They will expedite discharges, delay transfers from other hospitals, etc. So there's a whole bunch of things that they can do to try to keep things under control. Okay? And so we built a simulation model that actually included all of those things. And all of the surge capacity protocols were all kind of built because somebody thought it was a good idea. Nobody had ever really been able to test it. So we built a model that did test it. And the idea for this thing came from a hospital that called me up one day, and they said that they had an emergency department. The emergency department in Canada, frequently we have emergency departments that we run out of beds, so people are admitted but they actually sit on a stretcher in the emergency department. You can't get them upstairs. A lot of it happens in many hospitals in the US too. And this VP at the hospital called me up and said that what they'd done is they decided to build something called a medical assessment unit beside the emergency department for medicine patients so they could transfer them over there, look after them, and hopefully they were short stay and they could just send them home. And what they discovered is it worked really well for about 3 months. And then it was full and they were back where they started. She called me up to ask me if they should put in another 20 beds. When I stopped laughing, etc. Never mind. So we wound up building this model. And unfortunately, of course, I didn't have an instant answer for her. So by the time it took again another PhD student and spent 4 or 5 years building this thing, we were in fact able to use this at another large community hospital in the Toronto area. And they were building a new tower, and they wanted to look at the footprint for how they built it up. The second challenge, I'm only on the second one already. The second one is that we really need a strong champion. You need somebody inside. You can't go in from the outside. You need support from senior management. You need a strong internal team of managers and clinicians and analysts to do the hands-on modeling. And typically we need one kind of key collaborator to work on this thing. Okay? And all of my projects, I've had literally hundreds, and I would say all of my projects have a clinical or a healthcare partner. And there's a risk in relying on a single one. In the project in Saskatchewan, for example, project in Saskatchewan, I had one person at the Ministry of Health who really got it and she really understood it. And until she left and moved to another province, moved to Alberta. I heard a story about a hospital in Australia when I was visiting Australia. One hospital had 7 CEOs within a period of 8 years. And so it's really difficult in some cases to engage administrative and clinical partners. One of my best successes, as an example of a success, was a fellow by the name of Graham Woodward, who's Director of Planning at Cancer Care Ontario. Now, Cancer Care Ontario, they don't actually do cancer surgeries. They are actually the controller for Ontario population. Ontario has about 15 million people. It's a little bigger than, about 50% bigger than Michigan. In terms of area, it's about 4 times the size of Michigan. And CCO is an arm length data analysis policy advisor on all types of healthcare, started with cancer, expanded to a bunch of other things. I've spent a lot of time working with Graham on different projects, colonoscopy capacity planning for the province, thoracic surgery location. Which hospital should be doing thoracic surgery? It's not a good idea for a hospital to be doing occasional thoracic surgery. Volumes actually do imply quality. And we created an endoscopy efficiency toolkit that Cancer Care Ontario used for quite a few years. In terms of questionable success, we had a project called the Crowded Study. And the Crowded Study is an acronym, and it stands for Causes and Relationships of Waiting in Different Emergency Departments. And we think we got funded. We got $200,000 from the Canadian Institute for Health Research. And we think we got it because a lot of it was because of the acronym. Great acronym. And we started doing this. It was funny because we went out when we were applying for it. We went to 10 emergency departments and dealt with the management, and they said yes, they agreed to be a part of this study. And the idea was we actually sent people out for 2 weeks to collect detailed time study data on how long it took to process patients, for patients to go through. We were trying to look at how they were organized and how this was set up. So we had 10 emergency departments and across the province, academic, rural, community hospitals, and different geographies, et cetera. And so by the time it took a year, before we actually got the funding. And so then we set up the team and we set up our research team and we sent them out to the 10 hospitals. It turned out 5 of the 10 hospitals were under different management and they had no idea what we were talking about. I also relied on a PhD student to run the project, and he got distracted in year 3. He got married. They had a baby. They needed anyway. Never mind. He got distracted. He still tells me that he's going to come back and finish this someday. But it did turn into a different project that was developed looking at emergency department physician workload that was very successful. A project called the Power Study that's been published, and it worked out really well. And then a third one, just to give you an example of one that was a great work that turned into it went nowhere. And so we were looking at Ontario family physician practice location. And one of the problems in Ontario is that for family docs like to practice in the big cities. They don't like to practice in rural Ontario. So rural Ontario has a difficult time actually getting people to work in it. So we had a study. This was a funded research project. There was plenty of interest. We looked at a model for incentives. What are the incentives that you could create? The incentives that the government was using weren't working particularly well. There's a lot of publications. And so we developed models to look at how incentives could change the way family docs worked. There was a lot of interest, but there was no champion. And because there was no champion, who is interested? Well, everybody's sort of interested, but nobody really takes responsibility. Got some nice papers out of it, but it went nowhere for a PhD student. The third one I want to talk about is data, and so good quality data. Then if you don't have it, it's a real challenge. Here's Dilbert. Yeah, I need some data from unreachable guy named Ed. What should I do? Just make up a bunch of data like everyone else does. Everyone else does that? Are you doubting my data? Yeah, right. And anyway, so challenges. Now it's interesting too that hospitals do not collect process data, and so whenever I go to a hospital, and for years I go in and I say, "Do you have data?" "Oh, we got tons of data. We collect everything." And we got all kinds of data. Say, "Well, you do have this." "Well, no, we don't collect that," right? And I realized after a while, after being frustrated by this for years, I realized that hospitals are collecting data because the docs need it. It's clinical data. They need it because the bean counters need it, or they need it because the government or the public reporting needs it, or health records for legal reasons. Health records is collecting it for backup when they get taken to court. They do not collect data on patient flow. Nobody really cares, right? And there's no link before or after the hospital. Somebody leaves the hospital. They do not, typically hospitals do not have outcome data. There are HMOs that actually do that, but for the most part, when somebody leaves the hospital, they're gone. And you would really think that you'd like to know what happened to people a year out or 5 years out. And quite often hospitals do not know. So they don't really know if their processes work or not, right? And it's interesting, I had one hospital, for example, in an emergency department, they were tracking the location of the patient within the emergency department. So as they moved through, they went through from one place to another. They had a timestamp. This is where they were. This is how long they stayed there. And when the patient moved to a new location, they overwrote it. And I went, really? So everybody was in the observation, which was the last section of the emergency department. But they had great data, but nobody really cared, right? So it's a problem. One of the things about healthcare that makes me crazy is that healthcare still uses fax machines. Fax machines are everywhere. And I think it's unethical. I think it's criminal. I think people are literally dying as a result. There's a website called gregswings.ca if you want to go and see something about how bad fax machines are. And the problem, of course, is that because every pharmacy and every GP and every hospital has fax machines, how do you stop it? The UK has decided, the Ministry of Health, the NHS in the UK has decided they're not going to fund new fax machines anymore. They're not going to pay for them. But it's a huge challenge. And of course, there are privacy challenges, and there's lack of standardization. In Ontario, 85 to 90% of family docs have an electronic medical record, but they don't share it with anyone. So internally they know what's happening to their patients, but they're not sharing it with the hospitals, and the hospitals aren't sharing their data with the family docs. Privacy concerns, etc. And I think it's our fault. I mean, that why would they collect this data? Somebody has to tell them what to collect. Like, why do you need processed data? Why do you need to know what's going on? And I think we have to tell them that it's important. We have to tell them why. We have to come up with sort of minimum data sets on patient flow and patient care that we're not doing. Okay. As an example, a good example of cardiac data, in 2010, I was involved in a project, and this is a problem in Canada and in the US and in most other countries, that actually in the demand for cardiac surgery has been dropping. It's been going down. And the reason it's been going down is because of what's been happening in the cath lab. So in the catheterization lab, cardiologists, interventional cardiologists, are using catheters to do things like putting in stents or knocking out arteries that are blocked can be opened up with balloons and with stents. And so they don't need to have bypass grafts. They don't need to have arteries removed. There's some work being done in the cath lab on valve repair and other things, right? So the demand for cardiac surgery has been dropping. So what's happened is that new grads who are graduating from cardiac surgery can't get a job. And the Canadian Society of Cardiac Surgeons, they were concerned about this because, in fact, people were not signing up for residency positions. So in Canada in particular, in 2009, they had 11 residency positions for hospitals. Hospitals love cardiac residents. They do all the regular work, right? But unfortunately, there were only 5 of the 11 positions that were filled in the national matching program. For residents. They filled 1 more on a second round and 1 more international. They couldn't fill all the residency positions in the country. And the US is having the same issues, right? And so the Canadian Society of Cardiac Surgeons, the president and the vice president came to me and said that they wanted to look at, well, what was the demand going to be in 10 to 15 years? It actually turns out it takes 10 years to train one. So the question is not whether there's demand today, but the question of whether there's going to be demand in 10 years. And it turned out when we looked, we actually got really good data for it. I know the age, or I knew the age at that time, of every cardiac surgeon in the country. It turns out cardiac surgeons retire at 65, which was a surprise. The orthopods will work until their 80s. The cardiac surgeons go early. And we had a survey of all of the residents and fellows who were in cardiac surgery, because it's a fairly small profession compared to other ones, right? And we discovered that, in fact, that the demand, because of the baby boomers, the demand for cardiac surgery is actually expected to increase between 2010 and 2020. And it turns out that 50%, almost 50% of surgeons, the cardiac surgeons in Canada, were due to retire. So just at the time we're going to really need them, they're going to be, it turns out there will be a shortage around 2025. We'll see if that actually turns out to be true or not. So in fact, there is a demand in the future, we'll see. But we had great data, and we had great champions. A second one that was sort of questionable, the perioperative decision, the one I talked about before, the surgical simulation model. We implemented it in 15 hospitals, including the Victoria Hospital I talked about and some of the major hospitals in the Toronto area. But we had one of the hospitals we worked at. The hospital tells us, we went looking for data for these things, right? And one of the issues that we had to do, one of the things that we had to do was that we asked the hospitals, well, if you run out of time at the end of the day, you have to cancel surgery. And so we said, the OR starts at 8 o'clock and it finishes at 4. Well, what if the last patient, the second last patient took too long and there's no time for the last? What's the rule? Well, it depends. It depends on the doctor. It depends on the patient. It depends on the nurse. And said, no. Computers are stupid. We need a rule, right? We had, in our model starts at 8 a.m. And I can't tell you how many hospitals said, well, can you change your model so sometimes it starts at 8:15 or 8:30? Because we don't actually start on time. I said, no. If you want to program the thing to tell it to start late, go ahead, but be my guest. But don't pretend that it's 8 a.m. and it doesn't actually happen, right? And so these are the kinds of, that it was really difficult to get good data. I wound up making up rules for a lot of these things, and then we would run it. And it was bizarre because the results never actually match reality. And for the first few times we did this, I would, wonder if the model was right. Afterwards, I realized the model was perfectly right. People just don't follow their own rules. So it was great fun. And for most of the hospitals, in many cases, we discovered the docs were doing some very strange things that nobody knew about until we started running our model. And then my Ontario health system in terms of data, the one we were trying to, I wanted a model of the healthcare system. And we wanted to estimate the impact of major funding changes, what's going to happen. And some of the data is based on recent policy decisions. Mostly we relied on expert opinion. We had multiple experts, multiple sectors from different sectors, enormous data requirements, and a lot of it was just guesswork. It was just intuitive. So like one of our problems with this is that even though we could get the results in, like I said, order of magnitude, this was a real data beast. And of course, it was a real beast to keep up to date. Number 4, my fourth one. How am I doing here? Oh, not too badly. Okay. Fourth one is healthcare culture. I love those cartoons. I want you to find a bold and innovative way to do everything exactly the same way it's been done for 25 years. And if you think that's funny, you haven't been in a hospital long enough. It's really difficult to get people to change, to get people to move. And everybody's sort of pulling healthcare innovation. And so everybody wants innovation, the nurses, the payers, the government, science, the scientists, the doctors, the educators, the old industry, the inventors, everybody's pulling it at healthcare innovation, and they're all pulling in different directions. And the fascinating thing in healthcare is that my mental model is that nobody's in charge. If I went to the CEO of General Motors and said that, I can save you $1 million, if I could convince the CEO, that change would happen tomorrow. And if I went to the CEO of a hospital and said, I can save you $1 million, the CEO would say, well, that's great, Mike. I believe it, but we're going to have to talk about it. I've had CEOs of hospitals tell me they're not really in charge. Their job is facilitators. They are trying to get consensus. They are trying to get people to change. And it's a fascinating balance, and you can see all these people pulling in different directions, and the CEO is not running this thing, which is actually in some ways this is probably not a bad thing, right? Like In many cases, the doctors are in charge, right? So there's a lack of a single decision maker. And so one of the rules that I've come up with for dealing with this is that I try to optimize for everybody. And what I mean by that, what optimize for everybody, is that I've got a great solution. My problem X, I've got a great solution, but it's not better for the docs. Like the docs are going to have to, well, as long as you come in at 8 a.m. and you're not late, then here's my solution and it's going to be better. I'm going to get more patients through, etc. Well, that's not the way they work, right? Well, it turns out if it's not better for the docs, it will fail, right? If you come up with a solution that's not better for the nurses, it will fail. If you come up with a solution that's not better for public opinion or for government or administrators, it will not work. It'll fail. And everybody will look around and say, gee, I don't understand it. It was a great idea, Mike, but it just didn't work, right? If it's not better for the patient, well, I'm not sure anybody cares, but that's another story, okay? Everybody, in fact, talks about patient-focused care, but the truth is that what they're worried about is their own. I have a mental model of healthcare that everybody's working 110%. They're all working their butts off, but they all can't figure out why everybody else isn't cooperating with them. And they can't see it from that other person's lens, right? They're looking at it from their own lens. I love this this sort of model of the four faces of healthcare, and this was Shalom Gluberman and Henry Mintzberg. Henry Mintzberg is a major healthcare management fella, and Shalom Gluberman is a very interesting character. And anyway, so they came up with this model of the four faces of healthcare. So they said, so first of all, the hospital, when you look at a hospital, it actually contains four basic groups. So it's got the doctors, the nurses, the managers, and the trustees or the board of directors or something. That's what the hospital looks like. And this is any hospital looks like that, right? The doctors provide cure. So when the doctors, so typically the doctors, they'll look at your results, they'll look at your reports, and they'll say, okay, we're going to cut that out. We're going to give you this medicine. And they prescribe something, they prescribe surgery or medical care, and they leave, right? So you see your doctor for 10 or 15 minutes when they do rounds in the morning on weekdays, okay? The nurses do the 24/7 care. So the nurses are the one, when you hit the buzzer, the doc doesn't come, the nurse does, right? The managers provide control. So they're trying to control this mess. And, they've got budget to worry about, and they're trying to manage, the demands from all the different areas. And then the trustees represent the community. Well, typically the higher level of the community, but never mind. The interesting thing is the coalitions, the four coalitions. So at the bottom, you've got the clinical coalition. The doctors and the nurses are the ones who are actually dealing with patients directly. So they actually touch patients. The trustees and managers don't. The right-hand side, you've got the insider coalition. Typically, for most places, the doctors and the trustees do not work for the hospital. The doctors are typically paid fee-for-service, and they are independent, private business people, right? They don't work for the hospital. There are certainly examples of hospitals that have doctors on salaries. NHS that has a lot of that, et cetera. But for most places, they don't. So the nurses and the managers are the ones who actually work in the hospital, work for the hospital. The top is the containment coalition. The trustees and the managers are trying to control things and contain things. The managers on a day-to-day level and the trustees on a more broad level. The fascinating one is the left-hand side, the status coalition. It's the trustees and the doctors who think they're in charge. They're running the place, right? And none of them work for the hospital. So it's if you tried to run General Motors like this, it would fall apart in a matter of hours. But at the same time, the reason hospitals set up this way is because you do not want an MBA manager telling a doctor what to do for, like Mike Carter. When I go into the hospital, I want everything. And the doctor is actually looking out for patient care, etc. That's their job. This is not relying on the expectations, right? The doctor has to decide who goes first and who's most important, etc. It should not be a financial decision. So it's fascinating. Right? So in terms of, this is in culture, and I'll give you 3 examples. So one of them, again, back to my perioperative simulation, the surgical simulation model. As an example, so we wanted to revise an OR schedule to balance demand for beds over the week, right? And so what happens typically in operating rooms in almost every hospital I've ever looked at, because surgeries happen Monday to Friday, what happens is that the hospital beds will fill up by Friday and they'll be packed by Friday. And then it drops off over the weekend. On a Monday, it's the lowest level. Typically, the staffing level is flat over the week, at least Monday to Friday. And certainly the beds are. It's really difficult to ramp up, have more beds available on Friday. So in our OR scheduling model, one of the things that we've allowed for is to try to balance the use of resources. Now, you've got some docs who are just doing day surgery and other docs who are doing people who are there for 4 or 5 days. So by swapping days and putting different docs on different days, we can actually balance the demand for beds over the week and actually spread that out, right? And in this case, it's actually better it's better for the staff because the nurses don't get clobbered on Friday. It's better for the docs. It's better for the docs because high demand on Friday can cause canceled surgery. If you run out of beds, you cancel surgery. The docs are paid fee for service. They don't get paid. So it's a good idea. Now, mind you, I have to switch Dr. Smith and Dr. Jones because Smith won't get paid. Now Jones has to move because to make it better for Smith. But the docs sort of understand the basic principle. So we were able to do that and actually have it better for everyone. A down example, one that didn't work, was orthopedic wait lists. And this was one we were doing, orthopedic wait lists in Winnipeg, in Manitoba. And we had one of the problem we were trying to address was that when people go into their surgeon, people approach their surgeon and they need orthopedic surgery. And the surgeon says to them, yes, you need surgery, and I'm going to put you on the wait list, and I'll call you when we're ready, right? Now and the doc doesn't want to give you a date. The reason they don't want to give you a date is because in the meantime, they're going to get some emergency people. They're going to get people that really need surgery immediately. And the doc has a fixed amount of time per week of surgery time. And so the doc is going to get some more important ones. So they like to, the backlog of hips and knees, and the wait list in Ontario is, the target is to do a sort of standard hip and knee replacement within about 6 months. And so the poor person goes home and they sit there by the phone waiting for the phone to ring, and typically call regularly to see if things have changed, right? And so we developed a simple Excel tool. Another Ph.D. student developed a simple Excel tool to estimate the wait time. And the wait time was not based on, I know exactly how many elective patients are set up. I don't know how many urgent emergent patients are going to show up ahead of time. And so we had a queuing model that went through and said, well, here's a range. So I can't give you a date for when your surgery is going to happen, but I can give you a 3-week window 6 months in advance. And then 3 months in advance, we can narrow that down to 2 weeks, and a month in advance and narrow it down to 1 week, etc. So we can focus in, and so people don't have to sit at home and cancel all of their activities waiting for surgery. The fascinating thing is we were nervous about how the surgeons would take this. This was a center in Manitoba that does half of the surgeries for the province, all in one hospital, in Concordia Hospital in Winnipeg. And we were kind of nervous about the surgeons. They were fine with this. we got pushback from the surgical assistants. They said, well, it was extra data input they had to do at the beginning to come in with the estimates for the individual patient and then giving people a window, et cetera. Yeah, but you're not going to have people call you every 2 weeks to say, am I there yet? Am I there yet? So it's going to, never mind. Anyway, it hit a wall. Questionable one, surgical simulation. Surgical simulation. So at one of the hospitals for our surgical simulation model, one of the hospitals, the operating room planners, they were rebuilding. They were building they were going to tear out all the operating rooms and they were going to build a whole new set of operating rooms. And they were looking at how many, the ones they had were small. And of course, the equipment that's gone into operating rooms has increased. They really needed larger ones. So the question was, how many do they need? Do they need more? Do they need the same number, et cetera? And so they said, well, your model will tell us, how we're going to work. So they had a steering committee set up. They had multiple stakeholders. And the chief of surgery comes in. This is before we've done anything. We're just talking about how this model works. And he gets really hung up on validation. And, clinicians get kind of focused on randomized clinical trials. So how are you going to validate that the answer you give us is going to be, well, I can't do that. As a matter of fact, I read once that said randomized RCTs are only, 20% of medical interventions are supported by RCTs. And yet it is the gold standard in medicine. So docs talk about it all the time. But my models never have an RCT. I don't do a surgical intervention, that I tried 100 hospitals with it, 100 hospitals without it, and look at it can't do that, right? So what I do is I look at before and after, and I look at a before and after study, and I say, this is what I predict. Let's see if that actually happened or not. And my joke is nobody ever did an RCT on a parachute, right? Okay, so yeah. Here's another cartoon here. Just so you know, Dr. Cottman can be a bit condescending at times. Never mind. Okay. I pick on doctors. Some of my best friends are doctors. Never mind. Finally, my fifth challenge is managing expectations. And, people generally they don't understand. We talk about models. They don't really understand what we mean when we talk about models, but they think they do. People are looking for predictions of the future. We don't do predictions of the future. We do scenarios. And so, we go through, we have a long list of assumptions. And if all of these assumptions are true, then the modeling outcome appears highly likely. Okay. And, I don't really believe that we can predict how true these assumptions are. I do hope my models are close to reality once we get the assumptions right. People don't get that, right? They want a simple, they want one model for everything. They want a simple model. They want to use linear regression. There was, one study in Ontario that looked at a simple model for nursing resources for the province, and the model estimated that by the year 2050, everybody in the province of Ontario would be a nurse. In order to and there were huge cuts in the 1990s. There were efforts to close the gap and bring up the supply by 2000. And if you did a straight line approximation, it went crazy, right? So examples of linear fit, there's examples where linear fit works well. But, like a linear fit on incidence of disease. If the incidence of disease is going down, it's going to predict that the disease will be eradicated and eventually go negative. That's not what's going to happen, right? People don't understand models. So we have to do something. This is one of my favorites. This was 2010. This is 11 years ago, and this was economists with the banks did some analysis on provincial health spending, and what they were looking at was the proportion of dollars that were spent by the government in Ontario on healthcare. And so you see, this is from 1976, the government was spending about 31%, and by 2007, they were spending about a little over 40%. And so they built this forecast model, and they came up with, that they said, well, the headline said by 2036, the healthcare system is going to be taking up 80% of the provincial budget. Well, part of the reason that the provincial budget has been spending more on healthcare is that they've been cutting back on social services and education. And so, yeah, so the percentage has been going up. This is not the dollars that have been going up. And in fact, what has happened, in fact, in 2010, it was so close to 46%. In 2021, we were spending 37.5% of the provincial budget on healthcare, and that's including COVID. And COVID's been a disaster, right? So this forecast was crazy, but the government actually, the fellow who led this thing, Don Drummond from TD Economics, and the Liberals hired him to fix the problems because he was an expert. Makes me crazy. Another I think expectations. My whole system model, go back to my, the model of the healthcare system. It was fascinating. The guy who did it, I think what he really wanted was he wanted a little desktop model. The Ministry of Health in Ontario has probably 100 people who are doing policy analysis, and they're looking at papers. And he had imagined that everybody would have a little computer beside. They could type in a few things and it would come up and tell them how well their policy, what the KPIs were for their hot policy, right? And sort of, that we could do that for a few key levers and a handful of metrics, but it took actually quite a bit of work to get it down to that point. So it really, it didn't really. His expectations didn't match what we were doing. People want simple solutions to complex problems. George Box, all models are wrong, some are useful, absolutely. Albert Einstein, make your theory as simple as possible, but no simpler. Or for every complex question, there's a simple and wrong solution. I love it. As an example of, for healthcare expectations, one of the projects that we had several years ago was looking at cardiac surgery in Hamilton Health Science, and they had 3 cardiac surgical ORs, and they were building a 4th one. And so they brought us in to look at it. What would, if they add a 4th one, you're adding, they didn't want to add any new beds. They didn't want to add any cardiac intensive care. They wanted to be able to balance the demand over the week and still increase the number of cardiac surgeries that they did, right? So that was the plan. And so we used simulation modeling. And a fellow, the chief of cardiac surgery is a fellow by the name of Dr. Kevin Tail. And Kevin was really kind of skeptical from the first. But I had an MASC student, a master's student, who was working with him, Gene Young. And so Gene worked with Kevin and spent about 2 weeks going through explaining the data we needed and how simulation worked. And after a couple of weeks, the light came on and he sort of understood simulation modeling. And they had this one morning meeting at 7 o'clock in the morning. And there were five cardiac surgeons, and they were all there. And as usual, they were all on the other side of the table from me. And one of the docs asked me a question, but he asked me a question sort of shaking his finger at me, the way, that kind of a question with some sarcasm. And before I could answer, Kevin answered the question correctly. And everyone just went silent. And from then on, it was just brilliant, right? We just had to get Kevin in understanding and to understand the expectations of what was happening. It was lovely. Another one, final one example that was sort of questionable. We did some work along the same lines as doing the cardiac. How many cardiac surgeons is Canada going to need in 10, 15 years? And we did some modeling for orthopedic surgery, a lot more difficult in terms of data and problems. But we made a presentation to Bone and Joint Canada, and that there was a major shortage. At that time, there was a major shortage of orthopedic surgeons in Canada, 2011. There still is. And 2 weeks before we made that presentation, there were headlines in the national newspaper, the Globe and Mail, talking about, new orthopedic graduates can't get a job. And so the Bone and Joint Canada people said, well, wait a minute, what about this? if they can't get it, how can there possibly be shortages if people can't get a job? Well, the reason was that, in fact, that there were tremendous shortages because they were not getting, in particular, the docs who were graduating, who were foot and ankle, head and neck orthopedic surgeons, couldn't get a job. They couldn't get OR time. The hospitals weren't hiring. It wasn't because there weren't long wait lists. There were long wait lists, but the governments had not put any priority on that. They were prioritizing knee replacements and hip replacements and some shoulder stuff. But that was the rest of it was not working. We were both correct, but the expectations. People read a story in the newspaper, the journals. Well, they got it right. People didn't get a job, but it was a little bit anecdotal. Okay. And then finally, so the COVID-19 pandemic, right? So how does this turn out in terms of my 5 challenges? Well, definitely we've got a crisis, no question about it. Right? No problem. Plenty of champions, lots of people, plenty of people coming. My phone was ringing. Amy's phone was ringing, I'm sure. People calling up. There was plenty of research funding. It was impressive. The number of, everybody was putting out, thousands of dollars and hundreds of thousands of dollars call for papers. There were way more applications for funding research than there was money available, but it was astounding, right? And there were lots of champions. The data, well, there were no previous pandemics. People talked about pandemic. They went back to the Spanish flu of 1918, right? And how do you do it? And how do you measure it? There was very little data. We didn't know what was happening. I mean, we were looking at models, but they were making stuff up. The assumptions were wild. Okay. Healthcare problem, healthcare culture. The scientists couldn't even agree on what to do about COVID. Okay, and we had a crisis, but people wanted an answer ASAP. They wanted an answer immediately, and we didn't have models ready to do it. It was really difficult to manage expectations. Okay? And a lot of the stuff you saw in the papers was the SIR models or the SEIR models, susceptible, exposed, infected, removed, the compartmental models that made a lot of very simplistic assumptions that very few people actually understood. And, we're still, I think, the decisions came down to the politicians, in Ontario and like most places. There were scientific advisory groups that were saying this is what we should do. They simply made recommendations to the government, and quite often they didn't agree. And the government was making decisions based on whatever, a lack of data, and they were based on what they heard. It's a disaster. In operations research, and like I said earlier, that Amy and I wound up doing a lot of very simple things, simple models, queuing models, etc. But it was a real challenge. Okay. So I'd like anybody, any thoughts, if you agree with my list, what challenges you'd like to add, if you have experience in this, do you have your own examples? I'd love to hear about it. And then my final cartoon, this is the, at the blackboard, the mathematician at the blackboard building a model, and the middle is then a miracle occurs. I think you should be more explicit here in step 2. I call this Mike Carter solves the healthcare problems in okay. There we go. I quit. There we are. All right.
Mike, that was great. And I realize you can't see us. I'm not sure who you can see in virtual reality in Zoom. But I'm going to open it up here for questions from our room first, and then folks in Zoom can add a chat. Go ahead, Mike. If you've got something in chat.
I'm going. Yeah, I do indeed.
You're switching computers.
I'm going to sign off here. My wife is teaching a course in the same room. her start shortly, so I'm going to sign off on my hardwired computer and go to my. Never mind.
Perfect.
I'll be there in a second.
Take your time. Oh, great. Yes.
I actually want to change my question because it was answered during the.
You can ask a brand new question.
Okay.
All right. So Daniel's going to ask our first question.
Hi, Daniel.
Yeah, I mean, obviously for these 5 challenges, technical skills are important, but aside from those, what do you think are very important skills to overcome these 5 challenges?
Can you hear okay, Mike?
I'm sorry, beyond the 5 challenges?
Beyond the technical, what do you think are the skills needed to address those 5 challenges? Is that?
Yeah.
Yep.
I mean, I think that it's, it comes down to change management, right? So I think there's a change management issue that we have to be aware of. And I think just, when I go into an engagement now with a healthcare group, I keep those 5 challenges in mind. If you look at some of the literature, like I said, there's 30 or 40. And I think that the 5 that I've given actually encompass most of the major issues, and yet and they're easy to remember, right? And I can go in, for example, I have to optimize for everybody. So, if I just keep that in mind, and I go through and I look at my solution, and I say, well, is this better for the docs? Is it better for the nurses? Is it better for the public? Maybe even better for the patient, right? And so I think it really, I don't have a short answer for you. I mean, other than looking at some of the change management literature. Like I said, we went the cartoon about we want you to innovate and do things exactly the way we've been doing it for 25 years. That's serious. It's really difficult to get people to move. And first of all, I have to do all these things. And once I've done all these things, then I think I've got my arsenal of arguments for how we can move and actually make a change. I don't know.
Go ahead.
Yeah, Dr. Carter, you've clearly been involved in a lot of different projects, whether you were sort of deeply involved or just on the periphery. And I'm wondering how you feel about, like, looking back, do you think your ability to make an impact and actually see implementation for these projects through would be different if you or people in general were to focus more on a very specific kind of type of implementation or project, or if you think that casting this kind of wide net is still a good way to be able to make change, because sometimes there's factors out of your control and it's just hit or miss.
Yeah, that's a tough one. I mean, I think that I probably bit off way more than the average person can chew, right? I decided 30 years ago that people were not doing systems thinking in healthcare, and I wanted to change that. And I wanted to change that using anything I could. I didn't realize how big the challenges were, and because of that, I didn't turn my back on it. But I really do. I agree with you that I think if people are people should focus on, this is what I do, this is what I do well, and then understand how the challenges fit into that particular area. I think that, the other thing that's happened in 30 years is that healthcare is a lot more receptive. It's really easy now to find champions, and that was not true 30 years ago. It's actually really easy to find a lot better data than it was 30 years ago. It's really easy. It's a lot easier to manage the culture. Yeah, I don't know. I don't do what I did, no.
Thank you.
But I'm going to echo some of that, Mike. I think for a number of us, we sort of get pulled into projects feeling like we don't really have any idea of what we're doing. But there are core underlying commonalities. And so even though it feels like they're really different, a lot of times they are more common. And the other thing I'll add to that is I think credibility is really important. And so the more projects you do, the broader your sort of surface level knowledge is. And that surface level knowledge sometimes is what it takes to get people to feel comfortable enough with you that they'll then invest in you to help you learn more deeply about a particular domain. And so I have found that going broad feels more uncomfortable, but I think there's so much low hanging fruit that moving from one clinical area to another clinical area, you can pick up what you need pretty quickly, and kind of get your foot in the door. And then it's those champions who, I loved your example of the surgeon who started to understand simulation. And often what I find is our clinical partners are, they want to know everything. They want to be in control of everything. And so they will actually learn a little bit of linear programming, a little bit of simulation, a little bit of queuing theory, so that they can feel confident in what you're doing. And then they start doing some of the work for you.
That's right. That's right. Oh, absolutely. And when I started out, I honestly had a few people say, well, where'd you get your medical degree? And when I go into meetings now, there's a couple of people around the table who have heard of me. Right, and it makes a world of difference, right? So that, but you're absolutely right. I mean, I think that, and the other thing too is that in terms of having the ability to do it, my other favorite line is the healthcare is 30 years behind manufacturing and other service industries. For example, lean processes was invented in Japan in the 50s and 60s, hit North America in the 1970s, hit healthcare in 2005. I go like, it took that long, right? So anytime I go, for the most part, I mean, there are some things that are very technical, radiation therapy or things like that. There are some things that are very mathematical and very technical, but most of the problems that I find in healthcare, there are, it's well documented and published in other industries years before.
I think that's a great point. Mark, go ahead and unmute yourself.
Hey, Mark,
everybody. Good, nice to see you. So like Mike, I've been in this for a long time, not quite as long as Mike. Both, from the inside, working for healthcare systems, then, doing consulting and as a longtime academic. So I just wanted to kind of, get your thoughts, Mike, and everybody's actually. So for getting things done in terms of implementation, I've certainly found is easier when you're on the inside, when you're, you've got to live with the solution. You can't kind of, parachute in and unfortunately, during the kind of the cost-cutting years, a lot of internal ORIE groups got eliminated at hospitals, which, then made it harder to be on the inside. I've noticed now with the resurgence in, kind of the analytics, some groups are getting reformed, and it's been interesting. I've been contacted by people and, they want to ask questions, and they have this intense focus on the machine learning side of things. Like every problem now is a machine learning problem. Like, wait a second, there's a role for optimization and simulation and all those things that we do. So that's a challenge for our community, is to make sure that, all of a sudden just the conflation of machine learning with analytics doesn't, take away from some of the things that we do. But I also want a challenge to this community, you know, to us as academics. You know, in general, we're not incentivized to provide things like software and implementable solutions. You know, our incentive structure is still set up for kind of the publication world, you know, which is a reality of academia. And so then those poor folks on the, you know, on the inside who are trying to implement these new models are, you know, going from a journal paper to implementable work is a large gap. And the one example that I'll bring up, and I'll stop talking, is simulation modeling. You know, there's been so much great simulation modeling done in healthcare over the years, but often, you know, I mean, I've developed an ARENA and MedModel and a host of other languages, but they end up being proprietary and closed and not shared. And so, you know, I would love to see the healthcare simulation community, you know, start to share more. And obviously, if we had better open source tools, you know, trying to do a discrete event simulation in Python, it's doable with SymPy, but it's not like using a, you know, an animated tool. But I think our ability to share models like that has been done in other industries, like the telecom industry, they have great network simulators that researchers can all chime in on and share ideas. And I feel like in healthcare, we're still, you know, kind of keep recreating these same tools that then are hard to share. And we, you know, keep building yet another emergency department simulation model. So anyway, I'll stop, but that's just kind of my hope for the future.
Absolutely. Well, like go back to the first part. Absolutely, like, you know, I can't tell you how many people have called me up and said that, you know, they want to do a machine learning, you know, data mining, and again, like by my challenge about managing expectations, right? Like people are reading about, yeah, machine learning is the answer, and it's going to change healthcare and all the rest of it, and they don't realize that, you know, machine learning, like for facial recognition programs, required millions and millions of faces in order to be able to come up with one that actually pull things out, right? And we typically don't have the data to support that, but everybody wants one, right? Whatever the question, doesn't matter what the question is, right? I don't think that people really appreciate it, right? Yeah, absolutely. And the sharing part, absolutely, Mark, I agree 100% that, you know, that with the perioperative simulation model that we did, one of the things that we did was we made it we built it in Simulate, we built it in a standard pro, but we built it using an Excel interface. So it's got 35 spreadsheets that describe all the data. So we never changed the model. It's one model. And I'm more than happy to share that with people. I'm much more interested in seeing things get used. And you're right, Mark, you know, we really haven't gotten to that point yet, sadly. It'll come.
Well, with that, I think, is that optimism? I think it's optimism. I'm gonna declare it optimism, and let's go ahead and thank our speaker, and then we'll get you working on your reflections. And I think there will be a lot to discuss and reflect today. So thank you again, Mike. And I will renew as soon as I can get myself across the border.
Please, you know, I've no problem.
Thank you so much, Mike.
Thank you so much. And anybody has any follow-up questions or anything, my email, mike.carter@utoronto.ca. Well, let me know. I'd love to hear from people. Thank you for the opportunity.
Thanks again. Thank you, Mike.
Bye.